This is such an exciting time because, my whole career as a neurologist, when I was a medical student, they would say, if you go into neurology, you're not ever going to help anybody. That's just the way it works. And so all these years, neurologists are the guys who can always figure out what you have, but they can never do anything about it. So if you look at, medicine, the biggest area of biomedical failure has been what? Neurodegenerative disease. If you go in, if you have ALS, if you have Alzheimer's disease, if you have Lewy body disease, frontotemporal dementia, cortical basal degeneration, PSP, just go down the list. You can't do anything about these, and you give the next drug therapy, and they keep saying 10 years from now, we're going to have something that works. We keep hearing that, 10 years from now, 10 years from now. So this has been a real problem. And so this is an exciting time because for the first time, we're starting to see people who actually reverse their problems. So we've been working on this for 30 years in the lab. Very exciting to see it. As you probably know, Alzheimer's is the third leading cause of death in the United States. And how many people here see people who have cognitive decline? Yeah, most people. And how many people know their ApoE status? Maybe a quarter, a fifth of people, something like that. Okay, so again, as Jay just said, good idea. We've been told, you shouldn't know this because there's nothing you can do about it. Absolutely wrong. There's a tremendous amount you can do about it. In fact, there's a wonderful website, apoe4.info, over 3,000 people from around the world who are all ApoE4 positive, all sharing on a social network what they're doing, and most of them are on the protocol we'll talk about today. So as you know, the big problem with neurodegenerative disease has been that we don't understand. So what's interesting, when I was a little boy, there was a guy who said, I'm working on my second $1 billion. Like, wow, that's incredible. He goes, yeah, the first was too hard, so I forgot to skip in that one. And so I'm just going on to the second. And that's what we've done in Alzheimer's disease. We say, we don't know what causes it, so we're just going to cure it. Well, okay, we need to understand more about what's actually causing this. And so that's been one of the interests. 20th century medicine was about what? What is the diagnosis? Congestive heart failure, Alzheimer's, Parkinson's. 21st century medicine is about why. That's integrative medicine, that's functional medicine, P4 medicine, 21st century medicine, whatever you like, larger data sets to tell you what's actually causing the problem. And when we start to expand those data sets, we see, among other things, that there are subtypes of Alzheimer's disease. So the big problem has been people trying to treat it without understanding what actually causes it. So as researchers, you may spend your whole life on one theory of Alzheimer's, which may turn out to be wrong. It's been pretty disappointing. So the fundamental flaws in the approach that we've all taken over the last 100 years since Dr. Alzheimer first told us about this, attempting to treat without determining the cause, assuming that mediators or even biomarkers are the causes. So we say, amyloid causes Alzheimer's. No, it's a mediator of Alzheimer's. It doesn't cause the Alzheimer's disease, but it's important to understand what it does. Assuming that a single drug, why do we keep saying, okay, we're looking for that drug? Well, maybe that's not the optimal way to go. Collecting tiny pathophysiologically irrelevant data sets. We want to know what's actually driving this problem. Root cause medicine, as we've been hearing. Constraining clinical trials to monotherapeutics rather than programs. So we proposed back in 2011 the first programmatic approach to pre-Alzheimer's, MCI, and of course it was turned down by the IRB, and the IRB, this was in Australia, both the public and private, said, obviously you guys don't know how to do a clinical trial because you're trying to change more than one variable. And we said, obviously you guys don't understand Alzheimer's disease because it's not a one variable disease, as we've just been hearing. And then impersonalized therapeutics. Whoever said that each person should be treated exactly the same way? That doesn't work for any of these complex chronic illnesses. And then failing to iterate. So you treat them and then you just stay on that same thing. Life is more complicated. Maybe you have phase 1, phase 2. You continue to tweak. You continue to optimize. That's certainly the way you deal with your life. Why not with these complex chronic illnesses? And then applying the same rules to untreatable diseases that are applied to diseases with existing effective treatments. This is one that drives me absolutely crazy. So people say, well, there are all these things that you should be doing because you want to compare this to what's currently available. Well, wait a minute. If you've got a disease where everybody dies, the rules change. You have compassionate use. You're saying, look, anything we can do, this is an emergency, anything we can do to make people better is better than nothing. People will say, well, that's just anecdotal. Yeah, As one person said, I don't care that I'm not statistically significant. I am significant to my family. Okay. So this is different when you've got something that's untreatable. We want to pull out all the stops. And then assuming that there's a single cause for a single disease. And so, as you know, Koch's postulates, things are changing. When you look at TB, it always comes from TB. But when you look at Alzheimer's, there are many different things that contribute. Same with cancer, same with cardiovascular disease. It's not always the French fries when it comes to cardiovascular disease. It's different things for different people. And guess what? They add together to give you the syndrome that you call, in this case, Alzheimer's disease. And so we initially identified 36 different things. So ignoring the fundamental causes of disease. So we want to keep on asking why, and going upstream, and just as we were hearing from Dr. Lombard just a few minutes ago, we want to go upstream. Why did this happen? And as we were hearing earlier with the inflammatory part, why? Ultimately, we want to know the fundamentals. Are there toxins involved? Are there pathogens involved? Is there a change in metabolism? Are genetics involved? And is there trauma, physical or psychological, or both? Those are the things that are the upstream mediators. We want to know what are we exposed to, what's actually driving this process. Just saying it's A beta doesn't tell us why. Why is the A beta there? What's actually happening? And if it's inflammation, as we heard about before lunch, what's causing the inflammation? So as you know, it's a really sad state of affairs right now for Alzheimer's. It's almost embarrassing and very depressing. So the patients, as you know, they don't seek care. They know there's nothing that can be done, so they don't go in. They wait the longer. And so when you finally hear about this, things are very late. And we want the opposite. We want people to come in as early as possible. When they do finally go into their primary care person, the primary care person says, hey, I don't need a neurologist. I can write a prescription for Aricept. That's all that can be done. So why would I need anything more? So they often don't get a diagnosis. They don't get the appropriate workup. And then finally, as they progress, now they're going to go to the university center. And the university center is going to tell them, number one, I'm going to take away your driver's license. Number two, I'm going to make it so you cannot get any long-term care insurance. And we hear this story all the time. And number three, look, I can't help you at all. But could you come back every 6 months so I can do a spinal tap and renew my grant? And that is how bad things are today. And that's where this group has to change that. That's where integrative physicians need to change that. So with the way that we're currently going in allopathic medicine, are we really breaking through to an Alzheimer's cure? Is that really where we're headed or not? With over 400 clinical trials now and failure after failure, it's hard to know. And so groups like this are starting to think about a paradigm shift and say, what can we do differently to understand the root cause, to prevent it, to reverse it? And that's what's been exciting. And we've had now 30 years of looking at this problem. So we'll just spend a few minutes talking about what do we do to develop an effective treatment for an incurable disease. And the first issue is that we need to close the complexity gap. Nowhere else is there that we take a problem that's this complex and we take a data set that's this size. So if you've ever been in a driverless car, or if you've ever been in a plane where you've got a computer program flying the plane for you, then you have to match the complexity of the program with the complexity of the task, right? Well, with human beings, we don't do that. So the complexity of the problem is here, and the complexity of what we check, serum sodium, serum potassium, is down here. There's this massive gap. An engineer would be laughing at us, saying, what are you doing? You're taking this incredibly complex problem, and you're using this tiny, tiny little data set, and then you're saying, yeah, we don't know what causes it, we don't know what to do about it. Well, no surprise. So we need to begin to close that, and of course, that's what functional medicine is doing. And if you look at the approach, it's really interesting. The current standard is it's one cause, we don't know what it is, it's one disease, and we're looking for a monotherapy treatment. But the research suggests something very different. We find many different contributors to this problem. Initially, we identified 36. There are some more. It's going to be fewer than 100. There are many from epidemiology. There are many SNPs. We heard about several of them. So if we look at the subtypes, we can see 6 different subtypes of this disease. Not a surprise, it's a complex chronic illness. And of course, most people have multiple pieces here, but they often have one that's dominant, whether it's inflammatory, whether it's atrophic, what have you. And then, therefore, there are many treatments, and this is a personalized program for each person. The other thing that's really interesting to me is when we look at the major illnesses that are taking our lives, we expect for, we're used to in coronary artery disease, if you go in for a cabbage bypass, you're going to spend somewhere around $150,000, give or take. It's somewhere between 70 and 200. Now, you're not going to spend that. It's going to be supported, of course, reimbursed. If you go in for chemotherapy, it's incredibly expensive. Again, reimbursed. When you go in for Alzheimer's treatment, you get a drug that costs very little. And if you try to do anything else, it won't be reimbursed. If you actually try to address the illness itself, it's typically not reimbursed. So why do we think that we're telling people there's nothing you can do, but we really aren't trying very hard? So just to summarize a lot of research, Alzheimer's turns out to be surprisingly a protective response. When you, as we were hearing earlier, you make this immunological response, the innate immune system is activated chronically, and A beta is part of that activation. It is a part of the innate immune system. So, as we know now, it is, among other things, amyloid is a good antimicrobial, as Robert Moyer and Rudy Tanzi showed. It is also, by the way, a very good way to bind a number of toxins. So we think of amyloid more and more the way we think of napalm. Imagine you're a country and someone breaches your borders, whether it's a spirochete or whether it's a fungus or what have you, or whether it's an army, someone breaches your borders, what do? You put down something that will kill the invaders, but in so doing, you're reducing your own arable soil, you're moving back, you're living with a smaller network now. So therefore, you see this stuff and you say, oh, that's the cause of the disease. No, that's the mediator of the downsizing because you're using it to protect yourself. And as long as whatever caused this is ongoing, you're going to keep downsizing. You're going to keep putting the napalm down, and you're going to get smaller and smaller networking. So when we address it, we want to know, why did you have to put this stuff down? What happened? So inflammation, anything, for example, anything that activates NF-kappa B activates the enzymes that cleave the APP to produce the amyloid. So whether it's infectious, whether it's sterile, you're eating too much sugar, too many trans fats, all these things contribute. If you've got a leaky gut, you are contributing to increasing your own probability of Alzheimer's disease. And then, interestingly, your body uses the same approach when you have too little support. So whether it's nerve growth factor, BDNF, testosterone, vitamin D, estradiol, pregnenolone, free T3, on and on and on, nutrients, etc., you're saying, uh-oh, I need to downsize. I can't support the network that I'm trying to support. So you use the same approach to do that. That's type 2. And then exposure to toxins, such as divalent metals. One of the best binders we know, extremely tight binding to copper, for example, is amyloid. So divalent metals such as mercury, biotoxins, such as mycotoxins. So these form the basis for type 1, type 2, type 3 Alzheimer's disease and pre-Alzheimer's. Combinations are common. And then there are other inputs. Sleep apnea, as you know, 70% of people with sleep apnea go undiagnosed. Incredibly important. Vascular insufficiency, trauma, all of these trigger the same problem. So if you look at these complex chronic illnesses, what they really represent are signaling imbalances. Whether you're talking about osteoclastic activity outstripping osteoblastic activity, or whether you're talking about synaptoblastic activity, the ability to make and store memories, being outstripped by synaptoclastic activity. So we want to look at the very things that cause that. And if you now blow this up, so here's amyloid precursor protein right here in the middle. There we go, right there. Then this can be cleaved. It's literally a molecular switch. You cleave it at one site here, which is the alpha site right here. You make 2 peptides that actually support neurite growth, synapse formation, and inhibition of programmed cell death. On the other hand, you have a synaptoclastic side where you cleave at the beta, gamma, and caspase sites. You actually make 4 peptides, SAPP beta, A beta, JCASP, C31, that all do just the opposite. They are pulling back. Now, normally, just like you have osteoblasts and osteoclasts, you have this beautiful ratio. We're all actively forgetting the 7 song that played on the radio on the way to work yesterday, and we're actively remembering critical things that we need to remember. You're keeping only the most important things. But when you're unable to do that because you've downsized your network, because you're fighting infection, things like that, then you give up and you basically say, look, I'm going to hang on to what I have for now. I won't learn new things, because the chance that something new, the Friends rerun that plays tonight, is as important to your life as the ability to drive and do your job and remember the things that you're reading and math and things like this. It's a low probability. So you've made this strategic decision, essentially, when you lose the ability to learn new things. And then the things that we think about, mitochondrial changes, tau, things like this, are downstream from that. So in a mouse, and I think, how many people saw the thing that was that just came out, the big thing on base 1? So exciting because they got rid of the plaques in the mice. Yeah, these are mice that have mutations that are unlike 99+% of people, of humans. So not a very good model that the mouse shows for the human, because it's just making amyloid whether or not it needs it. In a human, you have reasons to make it for, again, 99+% of the people. So not a very good model, unfortunately. So we want to know, okay, we can fix this in a mouse by changing that balance, and we published that back in 2006. But what happens? What changes that critical balance between the synaptoblastic and the synaptoclastic in a human? And it turns out to be just what you would imagine. Your exercise, your stress, your estradiol level, your NF-kappa B, your inflammation, the germs you've got running around, the biofilms, whether you have a leaky gut, all the things. You can look at the connectomics of APP and see where this disease comes from. Say, oh, okay, these are the things that actually contribute to a human getting this problem. So this is why we tell people, imagine that you have a roof with 36 holes in it. A drug is going to be a really good patch for 1 hole, but you need more than that. So if you had the perfect Alzheimer's drug, here's what it would do. And this is why it's hard to get. And we've spent years developing Alzheimer's drugs. We actually have one that's in trial and another one that's just going to start in trial. But they don't cover all the 36 holes. They do one thing or a couple of things. And therefore, the idea for the future is you want to have a personalized program along with the drug. So we need to train physicians that not only understand the microRNAs we were hearing about a few minutes ago, but which is with the person on the left, but also get what the traditional Chinese physicians, the Ayurvedic physicians as well, get that, wait a minute, you need to look at the whole human being. You need to look at the symphony. It's not just one little piece. And of course, that's exactly what things like IHS are doing. They are training, right, the physicians of the future who actually understand both the microRNAs and the whole concert of the human body. It's critical. So what we want to do, we want to know the ApoE4 status. 0 of these copies, 9% lifetime risk approximately. 1 copy, about 30%. 2 copies, it's well over 50%. And there are 75 million Americans who have a single copy and 7 million Americans who have 2 copies. So important to know it, get on a prevention program early on. What this actually does is to increase inflammation, and therefore it increases your risk for Alzheimer's. But interestingly, it reduces your risk for parasite-associated dementia and also may reduce your risk for type 3 because basically you have a hair trigger. You're jumping on things earlier. And by the way, it also reduces your risk for macular degeneration. So this affects how you eat, this affects how you exercise, this affects how you live. It's not saying that it's good or bad, it's just that it changes the way you deal with various stresses, microbes, pathogens, toxins, so forth and so on. So you want to identify early. We recommend anyone over 45 years of age get a cognoscopy, just the way you get a colonoscopy when you're 50. Get yourself checked out, get your blood parameters checked out, check a baseline, which you can do easily online now, see where your cognitive status. So we want to And we want to identify the subtypes. So you don't want to reduce the amyloid until you remove the cause of the amyloid. And we've seen a number of people now who went on the trials where you reduce the amyloid without addressing the cause who actually got worse with this. So this requires a fundamental change in our thinking. Most people have about 10 to 25 contributors. We've never seen a person who has only one contributor. So you want to know, from what is the brain protecting itself? Chronic infections, oral bacteria, spirochetes, fungi, reductions in trophic support, toxins, what is actually going on? So you want to know synaptoblastic signaling, that's the good side, synaptoclastic signaling. Why are you out of balance? Everybody with Alzheimer's is out of balance. Too much synaptoclastic, not enough synaptoblastic. So your probability of developing Alzheimer's is proportional to the sum of your synaptoclastic signals, all the things that contribute, over the sum of your synaptoblastic signals. So you want to reduce the synaptoclastic and you want to increase the synaptoblastic. The major synaptoclastic signals, just what we've been talking about, NF-kappa B, other inflammatory mediators, homocysteine, PAMPs, so the pathogen-associated molecular patterns, things that activate your innate immune system. Insulin resistance, trophic withdrawal, suboptimal hormone levels, suboptimal nutrition, reduced protection, selenium, glutathione, things like that, toxin exposure. Major synaptoblastic signals, resolvins that we've heard about, anti-inflammatories, omega-3s, et cetera, neurotrophins, BDNF, NGF, NT3, et cetera, hormones, vitamin D, toxin reduction, nutrients. These are the critical synaptoblastic signals. So there are many contributors. We, as I said, initially identified 36. There's likely to be fewer than 100. There are probably 50, 60, something like that. But there are many things that we can identify. Simple examples. You can literally follow this, and I won't go into great detail. It's on the printout of the slides. It's also in the book. So you can literally follow these things directly as you can see how they activate Alzheimer's disease. And so you can follow each one of these things to show this is why these things either induce or inhibit. So here's an example, 66-year-old guy. He's actually now been on the program for a few years, doing great. ApoE3/4, amyloid PET, markedly positive, FDG PET, typical for Alzheimer's. Hippocampal volume was reduced, neuropsych testing, MCI at that point. You can see his hsCRP, 9.9, so shouldn't be more than 1. Homocysteine, 15, vitamin D, 21, testosterone, 264. He responded metabolically, cognitively, volumetrically. He did great. His neurologist told me he's now, quote, normal. Just had dinner with this guy the other night, and he's challenging me to memory tests and stuff. And you can see here that his hippocampal volume went from 17th percentile to 75th percentile. Having said that, we've now seen other people who have hippocampal volumes of less than 1 percentile improve clearly functionally better, and yet their hippocampal volume is still low. So we don't understand yet why this is, but there are people who clearly respond with increases in their hippocampal volume and some who don't. This guy's been on for a few years. Interestingly, he likes to cheat. So what he does is he adjusts the program till he has just a mild anomia and otherwise can do his job and everything. So I keep telling him, look, you just do a few more things, you'll be in great shape. He's like, nah, I like to do this. I like to cheat every now and then. So anyway, to each his own. So for type 1 inflammatory, which is what this guy has, you want to determine the drivers. What actually drove this problem? You want to start with pro-resolving mediators, followed by anti-inflammatories, pregnenolone of suboptimal levels. Curcumin, interestingly, as you know, binds to the amyloid, and also it has a nice multiple effects. It also it has a nice anti-inflammatory effect. So the diet, we call it Keto Flex 12-3. I go into it in the book about how to, and also on the website. So you want to achieve a mild ketosis, 0.5 to 4 millimolar beta-hydroxybutyrate. We recommend that people buy a cheap ketone analyzer. It's real easy. And so you can look at this. We typically recommend people fast 12 to 16 hours at night, more on the long side if you're ApoE4 positive. MCT oil, very helpful as part of a plant-rich ketogenic diet. And again, because of the time, I won't go through all these things, but these are things that all change that balance, and you've got a copy of this so you can see it. Spend a moment here on what these people actually take. So including where indicated nicotinamide riboside, magnesium threonate, resveratrol, pregnenolone, vitamin D3, citicoline, and DHA. Of course, Richard Wortman from MIT has spent his career showing that these help to build synapses. Alcar, which increases nerve growth factor, ubiquinol, of course, to support mitochondria, mixed tocopherols and tocotrienols, because of actually a trial that was done in the past as a monotherapy, but actually was one of the few that actually showed some promise. And acetylcysteine we've heard about earlier, ascorbate, B1, P5P, et cetera. And then obviously be careful about the source of your herbs. And there are different ones you can use for different people. In general, which has been around for thousands of years, bacopa, ashwagandha, turmeric, shankpushpi. In some cases, we like gotu kola for people who have issues with focus. Hericium increases your NGF. Rhodiola for people, again, who have cortisol issues. And then immune status. And there is this triad that the Ayurvedics like to use of tinospora, amalaki, and ashwagandha. So again, you're dealing with someone who typically whose immune system is not functioning appropriately or is over-functioning. After resolution, consider whole coffee fruit extract, which increases your BDNF, and then optimize all the suboptimal metabolic values. Some people like to use HBOT, some people like to use light therapy. Here's a woman with type 2, severe difficulty. So this is a kind of typical, no problems with executive function, unlike the type 3s. She's ApoE33. She had an FDG PET, typical for Alzheimer's, MRI hippocampal volume 16th percentile, online cognitive assessment 9th percentile, low vitamin D, pregnenolone, progesterone, estradiol, free T3, B12. So she had type 2 MCI. And she began the protocol. She actually wrote to me about a year and a half ago. Her cognitive assessment has gone from 9th percentile to 97th percentile. She wrote me this beautiful email about how her friends tried to cheat her at golf. And she's like, no, you did this, 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 this. And so her friends can't cheat her at golf anymore. So she knows what she's doing. Interestingly, her significant other said, your memory was disastrous, then it was just plain lousy, and now it's normal. So it was good to hear. And she had improvements, and as the metabolism goes, so goes the cognition. So you want to optimize all the trophic support, which is what we did for her. Be careful, obviously, a very controversial area is bioidentical hormone replacement therapy. And who here does BHRT? Okay, a few people. Again, optimal cognitive function for someone who's got cognitive decline includes optimizing their hormones. For these people, especially, whole coffee fruit extract may be particularly helpful. And we usually use 100 milligrams once or twice a day because this increases BDNF, and there's more and more work being done with this. Be careful about fasting, especially for people who have BMIs less than 20. So we typically want to cycle them. So you have them do their fasts for 3 or 4 days and then cycle off for a day. Not to say they take a bunch of sugar, but things like sweet potatoes and things get a little more complex carbohydrate in your diet just so you don't drop too much weight. And we mentioned the synaptogenesis with citicoline and DHA. Is there a role for secretagogues? I'm particularly interested in that. Theoretically, after you start to improve these people, growth hormone should actually be helpful to them. And there have been trials in the past using it, again, as a monotherapy. So it doesn't tell you much. They didn't work, but again, it was a monotherapy. Theoretically, you should be able, as you've now got the appropriate environment, you should be able to enhance these people. So we'll see over time whether that works or not. So here's a guy with type 1.5, fasting insulin, 14, HSCRP. So you can see he doesn't have a lot of inflammation there, but he's got insulin resistance. BMI was 33, normal copper, zinc, magnesium, et cetera. So type 1.5. And so you want to restore insulin sensitivity to these people. And again, I think you've got all this out on a handout, so I won't go through a lot of this. And then just to finish up here, here's a woman with type 3. So this is a person with exposure to toxins. This woman had a positive, amyloid positive PET, ApoE4 positive. Her MoCA score was 24 out of 30, so she's got MCI. Her onset was with depression, and when someone comes on with depression, be careful. They're often exposed to toxins. Non-amnestic presentation, that's another characteristic of type 3. And often these people start their symptoms in their 50s, which this woman did as well. They often have low zinc, low triglycerides, and a high copper-zinc ratio. She had all of those. Anti-amyloid therapy failed. In fact, it made her worse, as we've seen. Her C4a was high, or TGF-beta1. She was Marcon's positive. So she's been on the protocol for over a year now. Her MOCA's come back to perfect, 30, same as President Trump's. So we're happy about that. Mark may tell you that maybe it's not a sensitive enough test, I don't know. But in any case, Mark's, and I didn't say that, the neuropsychologist told me that. All right. So Mark's subjective improvement, and she's done very, very well. Her C4a has come down to normal. So just to finish up then, what we'd like to do now is to ask, can we take this same approach and can we make appropriate modifications to look at other neurodegenerative diseases? If we understand the biochemistry and the genetics and the epidemiology of each of these, can we actually now get this sort of approach where we're looking at multiple variables to work with these other ones? And the ones that are underlined, we've just begun to see the first few people and had some suggestion of success. So we're excited about that. This is where 21st century medicine is headed, and we call this the ARC project, because the ARC, of course, it was 2 by 2 by 2. We want to have just a few people with each of these just to see if we look at these larger data sets, can we actually have an impact on these people? So I'll finish there, so I know the time is out here. Thank you very much again for everything.